Hello, everybody. This is Dr. Albert Heuer. I am a professor at Rutgers School of Health Professions. I am also adjunct faculty in the respiratory care education programs at Rush University in Chicago, at Rowan University in Southern New Jersey, and County College of Morris in Northern New Jersey. I want to welcome you to A&T Lectures. I am co-owner of A&T Lectures with my partner, Terry Shenfield. Today, I'm actually going to be presenting on a topic that's near and dear to my heart. It has to do with patient safety, but it has to do with using capnography to help enhance patient safety. With that, I want to thank you for choosing A&T Lectures. I want to thank you for attending this particular lecture. And with that, I will go on and discuss learning objectives in the next slide. The particular learning objectives for this presentation are as follows. We'll explain the indications for end-tidal CO2 monitoring. The bottom line is this. If you can't answer why you're doing a particular test or a therapeutic intervention, you should question why you're actually doing it. So the foundation of actually doing both diagnostic and therapeutic procedures is understanding their indications. So we'll start this presentation with that. We'll describe, most importantly, how capnography can enhance patient safety. And along those lines, I really want to say that the indications and uses for capnography have expanded significantly over the past decade or so. And we'll talk specifically about those as well as the historic indications for doing capnography. We'll illustrate some of the equipment that's actually used, and there's different types of setups that you'll see, both for those that have artificial airways, so that are receiving invasive ventilation, as well as those that are not, that are spontaneously breathing. So capnography can be measured both, again, with folks that have artificial airways, that are in mechanical ventilation, as well as spontaneous breathers. We'll review the related research, both the traditional research as well as the research that has led to some of the more novel indications and uses. We'll review related, basically normal end-tidal CO2 values. So in order to understand what's abnormal and their causes, good starting point is to really look at what does a normal value look like and what does the capnograph, okay, the graph part, the graphic illustration of it, what is a normal value and what does a normal waveform look like? From there, we'll build on that. And we'll talk about defining what are abnormal values, their waves, and most importantly, their causes. We'll also talk a little bit about, what individuals can do as clinicians to try to normalize an abnormal waveform or value. We'll also identify the different types of waveforms, and again, the more common abnormalities we'll focus on because of time limitations. Lastly, we'll furnish additional resources for those who want to learn more about this topic and build on the foundation that both they already have and that this presentation helps establish as well. A good place to start is probably reviewing some related terminology. Capnography, I emphasize the graphy, is the analysis of the waveform or the graph. Often it's accompanied by a numeric value of the end-tidal CO2. Capnometry is the actual numeric value. Again, they're not mutually exclusive. Much of the equipment that's used to monitor end-tidal carbon dioxide will have both the graph and the number. A still related but somewhat different term is colorimetry, which is when I say dichotomous,
It's a measurement of, is it purple or is it a yellowish sand color? And what that actually means. In general, a change in color with the colorimetric indicator is a good thing, and it suggests that, for example, when used for intubation, that the endotracheal tube is in the trachea and not in the esophagus. However, there are limitations, and colorimetry can be less reliable than a waveform. For instance, in CPR, you have carbon dioxide buildup in the tissues and in the blood, but that blood may not be circulating very well. And as a result, there's little CO2 that may be reaching the alveoli in order to be eventually exhaled. So there can be little color change despite the fact the endotracheal tube is in the same or proper place. For a high CO2, the color may still say yellow after an initial change because, again, the level is so high, there's so much CO2 that's being expelled that the color change does not happen as it would without a CO2 that's that high. Some of the indications we'll focus on are, for example, monitoring ventilation or the adequacy of ventilation and gas exchange, such as that may occur in a mechanically intubated patient who perhaps is weaning on pressure support, or a spontaneous breathing patient who may have received some sedation to accommodate a procedure, or may have a progressive neuromuscular disorder resulting in, number one, the weakness in the respiratory muscles and the associated or concomitant buildup of CO2 because the minute ventilation is dropping. In addition, and as a point that I just alluded to, is monitoring patients who are moderately sedated. The term used to be conscious sedation, but we've gotten away from that. And generally speaking, when medication is administered to sedate a patient to facilitate, say, endoscopy, a colonoscopy or a bronchoscopy, that those medications are given to achieve this moderately sedated state or like a twilight sleep. However, those same medications can result in a suppression or depression of ventilation and can cause the buildup of CO2, which can be detected if the patient is indeed interfaced with capnographic equipment. Another traditional indication is what I alluded to earlier, and that is monitoring or verifying the placement of an advanced airway such as an endotracheal tube. An additional indication, and somewhat newer than some of the older traditional ones, is to check the effectiveness of cardiac compressions during a resuscitative effort. With all else constant, the better the compressions, the higher the CO2 level that is going to be indicated on capnography. A still even newer indication is to use capnography as a predictor of mortality in diseases or conditions like acute lung injury or ARDS. That is, the higher the end tidal CO2 for a sustained period of time, the worse the outcomes in acute lung injury and ARDS.
So as far as the equipment goes, there's an abundance of equipment that's used and supplies that are used in order to do capnography. And one of the more, and I mean traditional, primitive, older, if you will, types of supplies and equipment that are used are a colorimetric detector. And I'm saying it that way deliberately because it uses color change to give the clinical team a decent indication as to whether or not, in this case, the artificial airway has been placed in the trachea or the esophagus, or simply neither, but definitely not in the trachea. So what you'll do is you'll see a color change from purple to kind of a sand color, yellow, light yellow sand, if the tube has been successfully placed in the trachea. These colorimetric detectors have been around for a very long time. In many cases, many hospitals will actually have them in the intubation boxes. So to be clear, and I'll reemphasize this later in my presentation, but to be clear, end-tidal CO2 with waveform capnography, when it's available, is the standard of care. So if you're in an intensive care unit and you're either doing an intubation or you're assisting with an intubation and you have access to waveform capnography, it's going to give you the waveform, it's going to give you the number. That's the choice. The reality is, however, that in some or many cases, the intubation's actually being done perhaps on a floor, okay, on a medical surgical floor in a hospital. Maybe it's even being done in the field, where in neither case there is waveform capnography available. In those cases, the colorimetric device can be extraordinarily helpful. And this is a depiction or an image that shows you what they can look like. The larger one there, they are age specific, is for an adult. The smaller one is for a younger pediatric patient or a neonatal patient. And again, you will see that color change. There's actually a guide around the actual perimeter of where the indicator is to give the clinical team an idea of the color change and what it actually means in terms of the ranges of end-tidal CO2 that it's measuring. These are one-time use only, so these are to be disposed of. But again, they've been around for probably 20 or 25 years, but their introduction at that time was kind of revolutionary. And again, if you don't have access to waveform capnography, this would be an excellent choice. Now, this particular device, if you will, is a combination. It's both therapeutic and diagnostic. It's a nasal cannula. It's a nasal cannula that can deliver oxygen, as all nasal cannulas do, but at the same time, it can also monitor end-tidal CO2. Now, they're extraordinarily useful. They are becoming the standard of care when it comes to, we used to call it conscious sedation. Now we call it moderate sedation, where an individual, again, is given medication to put them kind of in a twilight sleep, perhaps to facilitate a bedside procedure, such as a thoracentesis or something along those lines. And when an individual is given that, or is given patient-controlled analgesia, that oftentimes they will be monitored with this dual device, giving a little bit of oxygen, maybe 1 to 3 liters per minute, and concomitantly or alongside that, there will also be their end-tidal CO2 will be monitored as well. Now, I have to say that these devices are not without their limitations. The higher the liter flow on the nasal cannula, the more dilution that can actually take place, the less accurate these devices can be. Just to be clear on that. Now you see kind of like a spoon shaped on the lower right hand side, a spoon shaped kind of whitish element to the nasal cannula. That actually would go over the mouth. So do also understand that if the patient is primarily a nose breather or is breathing with their mouth closed, that is something else that could distort the result as well. The last thing, and perhaps it's obvious, perhaps not, if the patient is hypoventilating. So now they have too much analgesia on board, they have a narcotic overdose, etc., etc. These devices either should not be used or they should be used with that limitation in mind. The limitation being this, that if a patient is hypoventilating or not breathing at all, but let's just say they're hypoventilating, so they're exhaling less CO2. It's being retained in their body, okay, but they're exhaling less CO2, okay, because they're hypoventilating. So it may understate or even grossly understate the actual, true value of the CO2 that's in the blood. Because again, I'll repeat this throughout the lecture, the value of end-tidal CO2 is the relationship between capnography and what is actually the partial pressure of carbon dioxide that's actually in the arterial blood. So again, these devices are extraordinarily useful, but like anything, it's not just you slap it on the patient and you just kind of go about your way. You monitor the patient and you keep these limitations absolutely positively in mind.
This is an illustration of an adapter, or one of the adapters that can be used to monitor end-tidal CO2 in a patient with an endotracheal tube receiving mechanical ventilation. You'll notice that the actual sampling port is facing down, which is incorrect, because what would happen over time is that moisture would collect in the sampling port and either cause an inaccurate reading or would disable the ability to get a reading at all. So the moral of the story would be to keep the sampling port facing up to minimize the likelihood and to maximize the utility of these devices. One of the newer indications is to actually, again, look at capnography during CPR to assess chest compression quality, also to detect the return of spontaneous cardiac activity. In the next slide, I'll show you a depiction of what that would actually look like. In some cases, capnography can also serve as objective data for the decision to cease a resuscitative effort. So for example, if the end-tidal CO2 is exceptionally low, let's say it's less than 5 or 6 or 7, and it's been kept that way a sustained period of time, it's suggestive that the blood circulation has been down for a long period of time and that the likelihood of a successful resuscitation is not good. The other end of the spectrum is when the end-tidal CO2 is very high, and it's very high for a very long period of time. It may also be an indicator that not so much in the circulatory side of things, but that on the ventilatory side of things, that the patient has not been ventilated well, and for a long enough period of time, that can cause irreversible damage. Some of the additional research that's been done was published, for example, by Sanders in the Journal of the American Medical Association in 1989, where these researchers determined that end-tidal CO2 correlates to outcomes in CPR. And I'll discuss some of those thresholds in subsequent slides. A 2005 study compared intubations that use capnography to confirm ET2 placement versus other methods, and it basically showed a 0% unrecognized misplaced ET tube versus a 23% unrecognized misplaced ET tube when capnography was not used. So the moral of the story with this slide is to confirm ET2 placement with waveform capnography. Some of the thresholds to consider regarding capnography and CPR are as follows. I'm always a little cautious to use a hard and fast cutoff, but just as a guideline, when the end-tidal CO2 is considerably less than 15, it's suggestive that the CPR needs to be improved. If it's greater than 15, it's also suggestive that the CPR, particularly the compressions, are adequate. In addition, the return of spontaneous cardiac activity can also be indicated when there's a sudden increase in the end-tidal CO2, sometimes as much as 10 or 15 or more within a few seconds, to a level that's in the range of 35 to 40. Again, that would be suggestive that, again, cardiac activity, that the heart has started to pump effectively for the patient. This slide is a graphical depiction of what was described in the prior slide. In that, you'll see on the left-hand side of this bar graph that the end-tidal CO2 is in the range of about 10. It vacillates a little bit, but it's in that range of 10 or 12, but it's clearly less than 15, something along those lines. If you look at the vertical or up and down bars, and each one of those bars constitutes the passage of about a minute, you'll see at about the 4th minute or so that there's a sudden increase in end-tidal CO2 to 50 or more, which is strongly suggestive that there's been a return of spontaneous cardiac activity. This would, of course, need to be confirmed with pulse checks and other methods to follow the American Heart Association guidelines. Another major indication for capnography is monitoring ventilation. Whether it be spontaneous breathing patients, who, for example, neuromuscular patients coming in for their regular checkup, or COPD patients that are doing likewise that don't have a neuromuscular disorder, but they're, if you will, prone to retain CO2. There's a Dr. John Bach, who's at a university hospital in New Jersey, northern New Jersey. Does a lot of work with neuromuscular patients. And when they come into his office, he will invariably measure their end-tidal CO2. And he has found that over a period of time, that the increase in their end-tidal CO2 will correlate with the progression of their disease. So as their muscles get weaker, the CO2 will tend to build up and be able to be measured in the context of capnography. With mechanically ventilated patients, looking at continuous non-invasive ventilation, so it can actually measure the adequacy of, if you will, the non-invasive augmentation that we're providing the patients with. For both intubated and non-intubated patients, it can, if you will, talk to the appropriateness of the settings. If it's non-invasive, is the difference between the I and the EPAP, the delta P, is that sufficient? If there's a backup rate, is the rate sufficient to keep the end-tidal CO2 within targeted levels? Also with mechanically ventilated patients, end-tidal can be very useful when, for instance, patients, number one, are being assessed for weanability. So if their end-tidals are very high, they may not be a candidate for weaning. Or if they are weaning, and we see a trend where their capnography is increasing over time, over the course of hours during the day, they may be tiring out. They may need to be put back on full support. So let's look at the numbers. The normal targeted numbers that we're looking for pH, 7.35 to 4.5. But in order to, if you will, maintain that pH within the targeted levels, the end-tidal CO2 would be in that 30 to 43 range. So in order to normalize with all else constant, the pH, the end-tidal CO2 would be 30 to 43. And it correlates to a PA CO2 of 35 to 45. So keep in mind that with all else constant and under normal conditions, the end-tidal CO2 will be below, okay, will be beneath what you'd get in a blood gas in the PaCO2 rather. You'll also notice that the scale is not linear in that the difference between end-tidal CO2 and PaCO2 is greater at the lower end of that scale. So at the lower end of the scale, you'll notice that a end-tidal CO2 of 30 correlates with a PaCO2 of 35. On the upper end of the scale, the difference narrows, with the end-tidal of 43 correlating to a PaCO2 of 45. So that difference is only 2. It narrows from 5 at the low end of the scale to 2 at the upper end of the scale. This slide just builds on the prior one by basically looking at your ranges, if you will. So PaCO2 greater than 45 correlate to an end-tidal CO2 of 43, and likewise with the alkalosis in the bottom part of the slide. that, if you're getting a pH that's greater than 7.45, if you will, the indicators or the correlating PaCO2 would be greater than 35. The end-tidal CO2 would be greater than 30.
So when I did the introduction to this presentation, I did mention that in some cases we'll talk about, now that you have, for instance, an abnormal value, what is the clinical team's response to that abnormal value? Now, you guys learned this in respiratory school. If you happen to be a nurse, you've learned it in nursing school as well. But it bears some repeating or review at this time. So the response to, broadly speaking, the response to an abnormal end-tidal CO2, how do we actually stabilize these values? Okay. If the end-tidal CO2 is high, you increase ventilation. Okay. And again, if the patient is mechanically ventilated, that can be done by increasing the respiratory rate, or increasing the tidal volume. The choice as to which you will select will often be a function of the patient's on mechanical ventilation, what their peak and their plateau pressures, their driving pressures are, what is their current tidal volume in relation to the predicted body weight. Okay, so if they're at the lower end, okay, if they're at the lower end of you're at about 6 mLs, 5 mLs per kg of a tidal volume, okay, and their plateau pressures in particular and driving pressures are okay. When we say that, driving pressure should be less than 15, plateau pressure should be equal to or less than 30. If you have room to come up on the tidal volume without, again, imposing excessive stretch on the lungs, you would aim generally in that direction. However, if you're already at a plateau pressure of 29, 30, 31, then perhaps you consider working the respiratory rate, as long as that doesn't adversely impact the IE ratio on the ventilation. Now, the opposite is also true. The opposite being, if the end-tidal CO2 is low, and let's say that it actually does correlate, which it often does, with what's actually in the arterial blood. So the patient has a respiratory alkalosis, you're going to do the opposite. You're going to decrease the ventilation. Okay. Now, if the patient's on mechanical ventilation and they are over breathing the ventilator, okay, you're probably not going to work the tidal volume. You're not going to lower the tidal volume because they're just going to breathe over that. Okay. So you're going to probably work the tidal volume and not the respiratory rate. So you're not going to work the respiratory rate if they're already over breathing the ventilator. You're going to aim to actually reduce the tidal volume in an effort to try to normalize that ABG and the end-tidal CO2. Now, if the patient is spontaneously breathing, here's another case. You want to look at the actual underlying cause. They may be breathing quickly because they need to compensate for a respiratory acidosis. So the end-tidal CO2 may be low, but they may be in a diabetic ketoacidosis. Okay. If that is the case, then you really, the team needs to actually treat the diabetic, the DKA, the diabetic ketoacidosis, or the other form of metabolic acidosis. Okay. If that's not the case, the patient may actually be alkalotic. They're not compensating for anything. They're in pain, they're anxious, they're just hyperventilating. In which case you really the team needs to treat the underlying cause. And if they're anxious, try to, alleviate their angst, by interacting with them, but they may need some medication to do that as well. If it's a case of pain and they're, again, they're breathing quickly because they're in a lot of pain, then obviously the pain needs to be treated as well in order to try to normalize the end-tidal CO2 and try to normalize the blood gas.
So how do you actually know whether to target the tidal volume, or the VT, or the respiratory rate? Well, one of the keys is you should really examine the current tidal volume relative to the recommended range of 5 to 8 mLs per kg. So for example, if you're seeking to decrease the end-tidal CO2, but your tidal volume is currently already at the low end of that range, okay, the low end of that range, consider increasing the tidal volume, perhaps to 6 or 7 or 8 mLs per kg. The other end of the spectrum would be, again, if you're looking to decrease the end tidal CO2 and your respiratory rate is near the lower end of that range, but the tidal volume is, let's say, in the middle range, it's already at 8 mLs per kg, but your respiratory rate is set at, let's say, 10 or 12, then look to increase the respiratory rate. Of course, looking at your IE ratio, evidence of auto-PEEP, and things along those lines. So absent problems with IE ratio and auto-PEEP, if you're looking to, if you will, decrease the end tidal CO2 and your respiratory rate is in the low end of the scale, increase your respiratory rate. So now let's look at the capnographs or capnograms. Okay. Again, looking at the actual waveform. So before we discuss what's abnormal, it's probably useful to look what is normal. Okay. In this case, what's normal about this? We're looking at shape. Okay. You're looking at the extent to which it's actually rising. So in this case, it's going to, you could see a demarcation at 0, 37, and 50. So it's going up to about 37, 38 to 40, okay, which is within your normal limits. And the waveform itself is actually achieving a plateau on the top, okay. Those are good signs. Those are very, very good signs. So the shape of this and the actual magnitude, the level it's going up to, look to be quite reasonable. Peeling away a few of the, if you will, layers in the onion here and looking at, well, what actually constitutes this normal waveform and what are the different phases, okay? So for the first part here, the line between A and B, essentially no end tidal CO2, owing to the fact that it's either a pause in between breaths or you have the beginning of the exhale process, very beginning of it, but whatever's being exhaled is not participating in gas exchange. So it's just not, it has essentially no CO2, and it's suggestive, again, it's a pause between breaths, or it's the very, very beginning of exhalation, and there is no CO2 in that gas. In this part of the slide, we'll actually look at the difference between B and C here. You see a rapid rise, and what's happening at the lower end of that, okay, by B, is you still have essentially conducting airways, so you don't have any CO2, but what's happening is you're seeing mixing going on, where there's some gas that does have CO2 from the alveoli that's mixing with that, and you're seeing this sudden rise from B to C. Between C and D, you now see what's called the alveolar plateau. So now you're seeing the end tidal CO2 that's being measured from the gas that's coming from the alveoli, that's participating in gas exchange. It's your highest reading. Again, that would be the number that would most closely correlate, or more accurately correlate, to the CO2 that you'd get on a blood gas, the PaCO2. So this slide is really showing you have a reading in that first breath there. It's probably around 30, 25 or 30 or something along those lines. The next breath it's less, the next breath it's even less, okay? So what probably happened here, again, we don't know for certain because we don't have enough information, but if we knew that this patient was being intubated, okay, and that this tracing was monitored during the intubation, it would be suggestive that the tube did not end up in the proper place. The first few breaths, there was some end tidal CO2 because there was CO2 buildup in the hypopharynx. So the area around the glottis, but again, not definitively in the trachea, because we don't see that good formation of a plateau, a rise, a plateau, and we don't see the repetition of this waveform. And this slide is basically showing you an increase, okay? You're seeing this rise, this sharp rise. It's a sharp rise. It looks a little like a shark fin, and it may well be indicative of some form of an obstruction. Could be an obstruction in the airway where you're not getting that sharp exhalation. You're getting some resistance to it. Okay, so this could be an equipment problem. It could also be a patient problem. It could be that the patient is becoming bronchospastic and there is, if you will, an obstruction to exhalation. So the shark fin pattern is one of the patterns that you'd look at or look for with patients that have asthma that are prone to bronchospasm, assuming you've eliminated all of the equipment-related causes.
Now, in the prior slide, we looked at a obstruction, whether it's in the actual patient's airway or it's in the breathing circuit itself. This is sort of the opposite scenario, where you don't have an obstruction, but you have a leak, okay? You have a leaky cuff, an endotracheal tube that's too small for the patient, et cetera, et cetera. And what's happening with this waveform is the waveform on the extreme right is a normal waveform. And again, these are really, they would be dragged out further. There wouldn't just be 3 breaths, but we're showing you this because we have, again, limited time and limitations of doing this in a PowerPoint presentation. The middle one and the one on the right-hand side, they are unable to achieve the plateau that you would normally see, because what's happening is the inspired gas, instead of going into the lung, some of that is actually leaking around the tube. And basically, a steady state of end-tidal CO2 cannot be achieved. And basically, there's mixing with air. And air has essentially, not no CO2, but very, very minute amounts of CO2. Okay, so you have that mixing going on. You have the inability to actually achieve and maintain that plateau. And the causes in this case would be a leaky or uncuffed endotracheal tube. It could even be a patient that has a positional tube where normally it's kind of okay, but their neck is in a particular position, or they're developing tracheal malacia over a period of time, and they had a good seal. Now it's, positional, or maybe not even holding a steady state, et cetera, et cetera. It may well be that they were difficult intubation, and the bottom line is they put in a tube to get a artificial airway to oxygenate and ventilate the patient. Maybe the patient had a lot of swelling in the upper airway. They were happy to get a 6.5 or a 7 in a large adult, but at the end of the day, that particular artificial airway is too small and really should be exchanged either by reintubation or by using a tube exchanger. Or, of course, if the patient can be extubated, that's a decent choice as well.
In this example, you have an increase in that plateau. So it's initially around 37, then it goes to 39 or 40, and then maybe it goes to 42 to 45. And again, if this happened over minutes and hours, it would be suggestive and point to a decrease in the minute ventilation. So perhaps the patient who's on pressure support is getting tired. Perhaps there's also an increase in CO2 production where the metabolic rate is going up. Or there's a rapid rise in body temperature, such as that may occur with a severe infection or even an injury of some sort to the hypothalamus. That's basically the thermostat for the body. There's also some less common causes of this sort of phenomenon where the patient has had a laparoscopic surgery. They've had a lot of carbon dioxide gas pumped into their, if you will, abdomen, if it's an abdominal surgery, so that the surgeon or surgery team could see what was going on down there and actually do the procedure. That CO2 is evacuated, but not all of it can be evacuated. So the body will absorb that. It has to go somewhere. It ends up in the bloodstream. It ends up, working its way to the alveolar capillary membrane to be exhaled. The other example would be not real common, but does happen. I've personally worked in 2 trauma centers where an individual may come in with a tourniquet. The trauma surgeons have gotten a hold of the patient. They're working on the patient. They've stopped the bleeding. They released the tourniquet, but you've had all of this, if you will, anaerobic metabolism that's been going on, buildup of CO2. Again, the CO2 now is no longer trapped in the distal or beyond the tourniquet. It's now allowed to actually enter the bloodstream, and it needs to go somewhere. So this is an example of a clinical situation that might account for an increasing, if you will, a capnographic waveform and end-tidal CO2 level, if you will. So a patient who's, let's say, naive to narcotics, they don't take narcotics at all or much at all. They receive a low/moderate dose of morphine sulfate of 5 milligrams for pain, let's say in the ED. But because they're so naive, they react to it in a very profound manner. Their ventilation gets affected by it. They slow their minute ventilation, and the end-tidal CO2 actually starts building up. In this example, you see a nicely shaped initial breath and actually subsequent breaths, but you actually see the plateau decreasing or declining, okay? And that's suggestive of, often either the metabolic state has gone down or the patient is in some way hyperventilating, such as you may see with pain or anxiety, something along those lines. So focusing a little more in depth on what happens with the bronchospasm waveform. And again, to remind you guys, I referred earlier to the shark fin shape that may accompany a severe bronchospasm if a patient also has end-tidal CO2 in place while they're having the bronchospasm. So think about what happens. The alveoli unevenly fill on inspiration. They also empty asynchronously or unevenly during expiration. So you get this asynchronous airflow on exhalation, which dilutes the exhaled CO2. So what it ends up doing is altering the ascending phase in the plateau. So you have a slower rise in CO2 concentration. You got the characteristic pattern, which again typifies a bronchospasm. And again, it's crudely referred to as a shark fin shape to the waveform.
So to build on the prior slide that really talked about what happens when a patient is in an obstructive airway from the standpoint of end-tidal CO2. So in the top, the orange depiction is a relatively normal capnograph. It doesn't achieve an absolute plateau, but it's nearly a plateau. Slight upward ramp there, slight upward ramp. With the bronchospasm, because there is this obstruction, and that obstruction creates a situation where a steady state is not readily achieved. So what actually is happening is the patient is going into the next breath before they're able to actually plateau. And this classic, if you will, shark fin depiction can often be seen. Now, I'm not saying that you should look at a patient, look at the waveform and say, oh, that's a shark fin. This patient's definitely having an asthma attack. I kind of do the opposite. I determine that, okay, the patient's diagnosis is status asthmaticus. They needed to be intubated. They're on steroids. They're on Heliox. They're on. And at the same time, we are happening to see a classic, shark fin depiction on the capnograph. And me being an educator, I would point it out to the team and just say, hey, listen, this is not an incidental finding. You never make a diagnosis based on this, but it's kind of a classic finding that with someone who's in a severe asthmatic episode, you will often see this depiction, particularly if they are, if you have a closed circuit, meaning if the patient's intubated and you don't have other issues going on, like a fast breathing pattern that's going to dilute, that steady state, et cetera, et cetera.
So some of the causes of an elevated end-tidal CO2 are as follows. On the metabolic side of the equation, you could have a patient who has what's called malignant hyperthermia. So you have, again, damage to the hypothalamus. So the body's thermostat is off. Patient is basically burning up. They're basically, producing a lot of CO2, and that CO2 could be measured in terms of an elevated end-tidal CO2. On the circulatory side of the equation, you have increased cardiac output with a constant ventilation. So the heart accounts for in the range of about 25% of the oxygen uptake and about 25% of the carbon dioxide production. So you have, again, increase in cardiac activity. Ventilation has not increased proportionally, and you can actually have more CO2 buildup relative to the the body's ability to get rid of it. On the respiratory side of the equation, respiratory failure, whether it's it's some sort of hypercapnic respiratory failure, perhaps a pneumonia superimposed on top of a COPD. Some respiratory depression, again, could be due to medications, neuromuscular disease, or some other related cause. Overdose or sedation, so a accidental overdose or illicit narcotic use, or just sedation when it comes to patient being given moderate sedation to facilitate a procedure. And an obstructive lung disease I referred to a little bit earlier on, whether it's alone COPD or you have something superimposed on top of it like a pneumonia. And there's always the chance that there's equipment failure. So defective exhalation valve on, let's say, a single limb circuit. We don't see them real often, We do see single limb circuits used with certain BiPAP setups, non-invasive setups. For instance, the Trilogy ventilator slash BiPAP, that can use a single limb circuit, and that exhalation valve can become, if you will, defective, or secretions could clog it up, something along those lines, which could absolutely cause the patient to rebreathe CO2 in an elevated capnographic waveform and numeric value. So, causes of a decreased end tidal CO2, pain and anxiety can, affect both the respiratory system and the metabolic side of the equation. With the respiratory system, patients in pain, they're breathing quickly, or they're anxious, they're breathing quickly, they're blowing off more CO2. So it's really alveolar hyperventilation, the two top, if you will, subcategories we have in this slide. Then beneath them, on the circulatory side of the equation, you're looking at something like cardiac arrest, where again you have oxygenated blood that's not being circulated through the body, it's not being able to pick up CO2 and return it back to the lungs. With an embolism or blood clot, the heart may be functioning okay, but there's a blockage, there's some sort of a blood clot that's preventing, again, the oxygenated blood getting to the tissue, and that has the venous blood that has CO2 getting back to the lungs to be exhaled. Sudden hypovolemia or hypotension, whether it's due to blood loss, whether it's due to some other things like septic shock, whatever, but that can also cause a decrease in end tidal CO2. As far as equipment goes, some of the things that we actually discussed previously in the presentation, there could be a leak in the airway system, a partial airway obstruction, or the ET tube is just not properly placed. It's not in the trachea, it's in the hypopharynx, or it's in the esophagus. So to come down the home stretch here, kind of summarizing some key points, capnography can be a useful assessment tool, but it's not perfect. Very useful potentially, but there could be equipment issues, there could be user issues, and you need to know how to, number one, interpret the result, and number two, once you properly interpret the result, be able to recommend changes that would remedy any abnormal values. In addition, understand that it's relatively simple and straightforward. Again, a valuable tool, and that a little knowledge can go a long way. But again, there's also indications, there's contraindications, there's limitations, and all of those things need to be kept in mind. Again, be able to hopefully begin to recognize, or recognize more thoroughly, the normal value and the normal waveforms, and then the abnormals, and some of the short list items of how to rectify them. And most importantly, if this topic is particularly interesting to you, you can go to some additional sources that will be able to help you out in learning more about these topics. Lastly, I just wanted to provide you guys with some of these selected references. The AARC, I believe we have all respiratory therapists that are participating in this session today, but if there are any nurses or any non-respiratory care professionals, the AARC is the American Association for Respiratory Care, and they have some very good resources on their website to actually help guide you, including that which pertains to end tidal CO2. One of my textbooks, Egan's Fundamentals of Respiratory Care, we just came out with the 12th edition, literally in the mid-spring of 2020. It's a great source. I'm putting a plug in for one of my own textbooks, but it is what it is. Likewise, my clinical assessment in respiratory care, we're currently working on a 9th edition. Most recent edition is the 8th edition, came out in 2018. My dear friend, mentor, and colleague, Dr. Craig Scanlon, worked with me on it. He passed away now a little over 3 years ago. So the current edition I'm working on, when I say alone, I have a lot of very talented contributors. But it's kind of this edition and the last edition were dedicated to his legacy and all the contributions that Craig Scanlon made to respiratory care. And then there's another outstanding source, Respiratory Disease, a case study approach to patient care, by Robert Wilkins. I believe that they're actually working on a new edition, even though it's been some time since this one came out. It's a great textbook that goes into the etiology, the pathophysiology, the clinical manifestations, and the treatment for all kinds of conditions, including respiratory failure. First two chapters are dedicated to respiratory failure, both oxygenation and hypercapnic respiratory failure. And then they actually cross-reference those two chapters throughout the rest of the textbook, which really is, basically is a highlight of the 25 most common respiratory diseases, and really drills down extensively on them. Lastly, and kind of combined PubMed and Medline. PubMed is really geared for more the layperson. Medline is more for the scientist. But you basically, a wealth of information on the most recent studies that have been done on a lot of these topics, including capnography. So I encourage you, again, if you have an appetite for this sort of thing, to drill down more on that. With that, Terry and I want to thank you very much for coming to this session. And we hope that you have derived some knowledge from this. We appreciate your coming to, the ensemble of CEUs that we've done today. And we really hope that you guys come back. Thanks a lot, and have a wonderful day. Bye.